Okay, so we have an awesome, distinguished panel today. I'd like to jump right in. So today we're going to talk about public-private partnerships. And I think it's really a great time to be thinking about this question. I think I'd like to start off by engaging on the why part of this question. So why do we want public-private partnerships? I think, so I work within the field, and on the sort of general purpose AI side, we've seen a bit of a gap emerging where there's less and less, at least on the surface, the first order, less and less engagement across public and private stakeholders in thinking about technology. Perhaps healthcare is meaningfully different, and maybe we'll talk about this a little bit. So we've seen, I think, on the healthcare side, maybe some more effort on collaborative initiatives between public entities, academia, private sectors, and so forth. I'd like to invite you maybe to first introduce yourselves briefly, and then say a bit on your sense of the why of public-private partnerships. And maybe we'll start from Nigam.
Intros first, and then?
Yes, please.
Nigam Shah, faculty member in
You
medicine.
may need to use the mic.
Oh, sorry, yes. Nigam Shah, faculty member in medicine and chief data scientist for the healthcare system.
Hi, I'm Laura Adams. I'm senior advisor at the National Academy of Medicine. I run the signature governance efforts at the National Academy of Medicine. And previously, I was a CEO of a public-private partnership, was a living laboratory in Rhode Island for data exchange. And before that, I was in senior leadership in health systems.
I'm Ken Harris, and I'm the vertical head for academic medicine at Amazon Web Services. And I've been in healthcare for 35 years. I've watched a long transition. You know, the last year have probably been the most exciting of those 35 years and also maybe a little bit frightening. So look forward to talking about it.
Okay, maybe you can start us off with your sense of the why.
Yeah, one of the things, so I run a team. My team are primarily MD, PhDs that are also informaticists or data scientists. So we have interesting backgrounds. And what we do is work daily with organizations that want to develop algorithms for clinical use, clinical research use. We don't really get very involved in basic science around algorithms. We really think about the translation into healthcare. And I'll tell you one of the things we've learned, and this is why I think it's absolutely critical that we go hand in hand together, that both private organizations like ours are there to help think about software transparency, software security, software modifications, and availability of the details that a developer is going to need to ultimately provide to regulators. But I think we need each other's skills. I think the earlier panel talked about the fact that we don't have access to the patient populations that are to test these things in real world use cases, but we do understand to a certain extent what the model was trained on and what it's intended to be used for. Where I said it's been a little bit alarming the last year, one of the things that I'm really, really concerned about and I don't have an answer for yet is data preparedness. And one of the things that we have seen, everybody thinks their data is fantastic and everyone thinks that their individual institution has enough data to go out and create a model that can be run globally for sepsis, as an example. That is not the case. And we really, really get surprised at the variability in data quality across healthcare providers and the capability of the data being ready for these types of models to train them. And I think that's an area where public-private, you have the data, we have the capability to dig in and also look across the spectrum to think about the safety of data. And I think ultimately we need organizations, it needs to be a tripartite relationship. We also need organizations like Chai, as an example, that help us test what we're building and validate it to make sure that what we've done is useful. Even if it's only useful for 5 organizations in a defined region and state, that's okay. But let's define that and state it.
Thanks, Ken. Laura?
I think it's happening now because people recognize that they have needs that they currently don't possess, skills capabilities that they don't possess that others do. I think we're also recognizing that we're never going to achieve the potential of this by acting alone. And it's exciting to me to see for the first time that we're really talking about this in a very open, transparent way. Maybe it is something that we learned from EHR implementation. I did so much work in that arena that I feel like I should be doing penance now, because I had no idea that it was designed primarily as a billing mechanism at the time. I could just think about getting our data for patients digitized. I couldn't wait. So when I think about it now, I think that there are primarily the public-private partnerships that I'm seeing that I think have the most potential are academia, private sector, and the public sector. And what each of those needs from each other are things like there's a public credibility aspect that's needed. The government can bring that. Academic medical centers can bring that legitimacy by publishing something. There's something that can come from the accessing the innovation and the technical expertise, the compute time, all of the things like that that come from the private sector. And all of us are better than any one of us. And we're recognizing that when we come together, that we just don't have a prayer of reaching the potential of this unless we understand how to interact with each other. So to me, this is one of the most exciting times too ever in my career.
Thanks, Laura. Nigam?
All right. Thank you for bringing up Chai. Brian was here somewhere. Yeah, there he is, the CEO of Chai. And we helped, Stanford is one of the 4 sites that helped start it. I speak in bullet points and in numbers. And sometimes they tend to be very direct, so just preface it up front. But the answer, in my mind, is scale. And Maya just brought up in the previous panel this question of how do we do this? There was rigor and what was the other word? Speed, time. And these are her ballpark numbers, which I'm sharing. So full credit goes to the AD department and to Maya. Doing the science right for one model, it's about 10 years and $28 million. If each and every one of the 123 fellowship and residency programs wanted to test and deploy one such model at that level of rigor, our current ways of organizing work, and let's say they want to do it at each and every one of our sites to make sure it works properly, the $138 billion. We can't afford it. So we have to find a way to scale, and we have to scale doing good science. We can't sacrifice on quality. And the skills for rigor reside in one place, and the skills for scale reside in another, and hence we're going to need these kinds of partnerships. Otherwise, as a nation, we're not going to scale.
Thanks, Nigam. I'd like to encourage you start preparing questions. This is an excellent opportunity to ask deep experts. Also online, if you're thinking of questions, we'll have time to answer some of your questions in a few minutes. So I think some of what you're bringing up now, which is quite fascinating, is this question of values, which can differ. I think this is one of the big challenges in really getting the partnership right. And I wonder if you'd say a little bit, in your sense, of what the values might be across the different stakeholders, where you see conflicts might arise, and what makes it easy or hard to really get the partnerships right when it comes to getting these sort of value signals and aligning them. And maybe I'll start with Nigam this time.
You give me the tough question. I mean, in healthcare, values has been an elusive quantity for quite some time. We have had the phrase value-based care for quite some time, and it's kind of hard to nail it down. Value for who? Mm-hmm. And what seems valuable to me as a patient might not be valuable as a professional society, might not be valuable as a provider, might not be valuable as a payer, or even as a nation. And so until we nail what is our definition of value, I think we're going to keep paying a little bit of lip service to value-based approaches. Now, in the context of the public-private partnerships, I think there are the skill and asset mismatch that leads to such synergy that there is value, everybody will agree. And I think the conversations will have to focus around how are we going to share it. And I'm sure it has come up in your conversations about data. Every organization thinks that their data are so valuable that you shall pay millions of dollars to access it. But then on the other hand, we want models that generalize to multiple populations, which can't be done without pooling everybody's data. So I think what we need to focus on is how do we first create shared value so then we can have the luxury to argue about it and how to divvy up.
Some
Yeah,
thoughtful
Nigam,
conversation, Laura.
you said earlier something about we all want a learning health system, but nobody wants to share their data. And I thought that was just brilliant, so I'll take it and repeat it. That idea of getting these things up front established and discussed in public-private partnerships, to me, is the key to success or failure. To get that, and when I think of what's value, I think of why are you here? Why are you at this table? What's the interest that you have in this public-private partnership? And if I don't deeply understand that, we've got trouble from the beginning. So I really want to understand why a public entity might come into this. What are you looking for? Operationally, when we think about what the government needs most is operational excellence and skill. They don't have the ability, they've got policy galore, but it's their ability to execute operationally that they're looking for in that. They're also looking for something that's going to be broad public benefit. You know, you've got to really understand deeply why each party is at the table, and that's where the values emerge. And I feel like some of the strongest work we ever did in my public-private partnership was to continually work on that because they changed over time. What became important to people in the beginning wasn't the same thing as we were 5 years into something. So that constant discussion, Stephen Hawking said that mankind's greatest achievements came about by talking, and our greatest failures by not talking. So that idea of bringing people together and having that constant conversation about what is our North Star, and are we still headed toward it? The other thing I think is important to get straight ahead of time is how do we make decisions? 3 things about public-private partnership. You share risks, you share resources, and you share decision-making. And getting that decision-making process nailed ahead of time saves a lot of heartache later.
Yeah, one of the things I think, you know, from Amazon's perspective that we think about for our value, and going back to kind of this tripartite requirement to ultimately to reach the end goal. One of the things we recognize we have to carry our water for in this public-private partnership piece is we have to find a way to lower the costs of AI as a whole. 100x for healthcare from where it is today. It's not affordable on a per instance or per question basis. The healthcare is going to be able to use this. I think when you think about value and responsibility, I think that falls on us to bring that piece to the partnership. I think the second thing that we have to bring to the partnership is we always have to be through the lens of the clinician and the patient. And, you know, I brought my team together last week in Chicago, and we spent 2 days really saying, like all of them, I told them, I'm like, you're not selling a generative AI model, you're not selling infrastructure, you are sitting between the ones who develop the large language models and the ones who want to use them and make sure we can translate that. That's also part of our value. And then I think that the third piece is really we have a responsibility to educate. And we probably won't educate the patients. That's probably up to the patient provider. We probably will not educate you know, the general population as a whole, but we can carry the education burden on regulatory, and we can carry it as well in our own internal engineers, and to connect those people that are developing products, that there is a patient on the end of every one of those questions and what that means. And then finally, I'm going to add this because I think we have a responsibility to the environment. And generative AI is hugely draining on the environmental resources. It uses a lot of water and a lot of cooling, et cetera. And if that's not at the forefront of our mind, we will drive ourselves into creating machinery that we actually can no longer sustain or operate. So
That's excellent. So while we wait for folks in the room, I see some hands actually, so we can maybe take some questions. Microphone, yes, thank you. Please.
Hi, Mildred Cho at Stanford. I'm wondering if you could say something about how in these public-private partnerships the true public voice can be injected into it, and how conflicts of interest can be avoided. How can we avoid AI not being even unintentionally used to deny people care inappropriately?
I don't know if you would like to, yes, please, Laura.
For us, it was complete transparency in our behavior, as well as the things that we talk about with regard to AI models. So our transparency meant our board meetings for a public-private partnership were public. They were open. Obviously, we went into executive session when we needed to, but when those board meetings were held, the press could even be in the room. We wanted to make sure, we knew that our only currency was public trust in this public-private partnership. If we were going to be, people were concerned that we were going to be amassing data, putting everyone's data in the center. People were reminding us, you lose this data, it's like slitting a feather pillow in the wind, you're never going to get it back. So we knew that there was high angst around there, and we needed to earn the public trust in this public-private, and we needed to earn the trust of each other and make sure that everyone adhered to the professed North Star. And what helped that was to constantly refer to it and point it out, but also to make our processes as transparent as possible. And also, it helped in terms of when people had a temptation to head off in another direction. It was very hard to do that because things were so public. And so our decision making was also very public. So if we made a decision that some people weren't totally supportive of, we made sure that we had a consensus decision-making process among the board, which said, it doesn't mean that you necessarily agree with this, but you can support it when we leave this room. And so those were some of the things, but our public voice is that we just brought them in when we got ready to design our privacy and security framework. We listened to all these voices. The ACLU sent us a letter 30 seconds after we got our first award saying we were going to, well, not 30 seconds, but, and they said, you're going to do what with all these patients' data? I don't think so. So we just said, yeah, you're on the committee. Coalition Against Domestic Violence said, you're going to gather up data. If this abuser knows that someone's broken her ribs the night before and you tell a doctor in the emergency department, you lose that data, you'll cost her life. I said, well, you're on the committee, because I didn't know. What I didn't recognize is that was very robust community engagement. It was just ignorance on my part and a sense that I knew these voices were important.
Nigam, please.
So I think one very concrete thing we can start doing as a community is to explicitly state and verify the presumed benefits that we hope to get by using whatever AI gizmo that we're talking about. And just like we register clinical trials, just like we register observational studies, use of models, we should be able to make a public commitment in front of the press and patients and say, this is what we hope to get. And if we don't get it, we're going to turn it off. We need that level of transparency if we expect people to trust us with their data.
Ken, would you like to?
Well, I just make two comments on that. I think we have two different questions to always ask ourselves. And in particular, an academic institution like Stanford has the question of, creativity, ingenuity, ideation. You have to ask the question, should this model be developed? That's one side of it. Then we, on the practical side, have the question of, should the model be used and for what? And again, I think really the should it be used and for what, I don't have a clear list right now that I could point to in healthcare. I think we need that list ASAP, where creative people come together and say, these are our priorities. And then we can let the ideation side and engineering, computer scientists decide if they can make it and should they make it.
So one of the comments that has come up, I'll take a quick online question and we'll go back to the room, is this question of the pace of innovation and iteration and different stakeholders. I wonder if you'll comment briefly on, again, I think for this partnership to work, there's some notion or some space for trying to figure out how to build consensus at speed. I'd wonder if you could say a bit on if you think that there are good practices for thinking about how to do this now and maybe in the future. Anyone can jump in.
We got to make time for it. Like a lot of places, the work to be done about rigor, about data cleanup, about partnerships is done in people's ample free time. If we really care, we have to allocate time to it, not just money, time and attention.
I want to give credit to the Biden executive order where they said in 90 days we want you to stand up a public-private partnership, which was the National AI Research Resource, and they stood it up. There's 25 private companies in there. Every big name known to man is there. And some others that are not such big names, but they're also really good partners. There's 12 of the federal agencies there. The National Science Foundation is the lead on this, but NIH is involved, the Energy Department is involved. It's just absolutely phenomenal. I saw a presentation on it a couple of weeks ago. That's the kind of public-private partnership. They moved very quickly to stand that up. There's all sorts of in-kind resources being developed and given to this partnership so that people who don't have access to research quality AI tools can get access to it so the research can accelerate and move forward. I think that's a model that we should be replicating at lightning speed across the country.
Yeah, I think it's interesting. New England Journal of Medicine AI publication just came out in April, testing large language models in oncology, and it was already outdated. So I think we're at a different pace today of our old world of science and when we get there. But I think we have a fundamental question to always ask when thinking about a model is what is the minimally viable product? What is the minimally viable outcome that we want to go for? If a clinician is only 60% accurate without a phenotypic background on a X-ray read, is better than 60% our minimally viable product acceptable? Is that what we're going for? And I think we have to be very fair to the models as well, not to expect things from them that are unachievable, A. And then, B, really thinking about, okay, we have our MVP, we want to improve that, but also not going for the newest shiny object in the room. What is the latest model that was introduced yesterday? I think someone said GPT-4o. Talked about last night, because it may not move us. Yeah, it may not move us to that better endpoint. We may not need to be there. And so I think that's on pace. Do what we need to get done and don't chase shiny objects.
Could I just follow on for 1 second on? I think that it's critically important for us not to compare the AI performance to perfection. It's so important for us to say, is it better than what we have today? I think about how people fought against electronically and digitizing our data because, gee, it wasn't going to be perfect. And I'm thinking, people can be crawling all over your records right now, those paper records, and sort of dusting for fingerprints. You're not ever going to know. There's some advantages here. We're going to know if someone logs in and looks at your record. But there was this comparison of the new system to perfection, and the old system's fallible as all, get out. I'm from Colorado originally, and why compare it to perfection? I think that's just a concern that I'm seeing now is let's take a look at, is it better than what we have now?
So we'll take some audience questions. Because of time, I might ask one panelist to respond to each question. So please. And then we'll try to take a few before the break.
Hi, K. Narayanan, CEO of Ascendo AI. I've been a technologist for over 35 years, primarily in the enterprise space. And just listening to everybody here in healthcare and hearing about transparency and ethics and accountability, we have solved a lot of these problems in a very different way in the enterprise side of AI, not in the business to commerce side of AI. And the same thing with patient engagement and patient value is also we have looked at it from a customer engagement, customer value, and brought in various solutions to the fold to help with this. From a private public partnerships that you guys are all thinking about, is there a way to bridge the gap between the enterprise AI side of it with the public side of it instead of the B2C AI side of it to the public side of it? Sorry, it's more a technologist question. I can point it to Nigam or
anyone
to Ken.
Who feels interested.
All right, I get the tough one. So I'm going to simplify the question as I understand it, which is how do we bridge the gap between the B2C mindset versus the enterprise sales mindset, and how does a public-private partnership function in that case? So absolutely right that in an enterprise sale mindset, public doesn't mean, say, the voting public. But we need representatives from them on their stakeholders, patient advocacy groups, and so on. So for example, very sort of mundane thing, most hospitals use something for clinical documentation integrity. And there's AI that will then assign codes, help you produce a report that you submit to the insurance companies, and so on. usually there are no patients involved. And in the case of a public-private partnership, that kind of AI would have a testing and evaluation framework that is agreed upon by a large group of stakeholders, such as convened in Chai. And that testing and evaluation regime would be applied when an enterprise is buying a product from a vendor. So that's my way of thinking how we would bring that public voice into that conversation in an enterprise AI setting.
Thank you. Please.
First of all, thank you all for the time and effort on this panel. My question is more around what Dr. Yodam was talking about earlier. There's a lot of work, and Nigam, you well articulated the expense of that. But where do these public-private partnerships fall in affirming some of these technology? AMCs are uniquely positioned, potentially, with some of the resources they have, industry is, in affirming some of what these technologies can actually do before they get out and are actually in clinical settings.
And I forgot to mention this, but if you please introduce yourself.
Oh, sorry. David Entwistle with Stanford Healthcare. Yes.
He's the CEO.
For the audience. If anyone is interested in answering.
I'm happy to take that one. So I look at models on behalf of Amazon in a couple of different ways. So we get requests coming in all the time that, hey, I have an idea. I want to take Llama 2 and run it against, this data set, et cetera, ultimately with the idea of putting it into clinical practice for pediatric care. So we listen to that, and it always comes with $1 million price tag. I will just tell you straight out, everything starts with $1 million and goes up from there. There's nothing less than that. And so when you're really thinking about, if you're asking us to write a check for $1 million or more, we're really going to kick the tires on it, first of all. Do we think it is adding validity to the model? Is it adding value to the space or to healthcare? And do we actually think it has a probability of being successful? And it takes us a long time to come to that conclusion for that kind of money. And what we're doing as an organization is now starting to rank some areas where we think we should be making investment and seeking those public-private partnerships out right up front, with the idea of me thinking in the back of my mind that somehow Brian's organization is actually going to be able to certify that and make it viable in the marketplace. Because if it doesn't get used, it's just an academic exercise. So I would really tell you we could put $1 billion out today in grant funding for large language model ideas, and it would be sucked up overnight by academics. And we've got to find a way of harnessing that towards viable applications in healthcare without stifling creativity. And so actually at Amazon, we're bifurcating them. We are looking at them from a purely research standpoint that we just want to understand and invest in, and from purely the clinical decision support side of healthcare. Two different pools.
Okay, please.
And I think we should probably remember, too, that we can validate in the AMCs and other places as soon as we take it out to the inner city hospital in Chicago, we take it to the community health center down in Mississippi or the rural hospital in Nebraska. We've got an entirely different challenge there. It's got to be just as viable and tested in those environments as well.
Nigam?
I think we're going to have to start thinking about software as health systems. Like hospitals have mastered logistics, they've mastered supply chain, food services. At some point, we're going to have to learn as health systems software. Because one of the guaranteed ways to drive down cost of doing business, particularly the kind of rigor and reproducibility and that we need, is turn things into software. Imagine if SSH was an algorithm that each one of us maintained separately for organizations. How expensive would encrypted transmission be? Like, we need to get to that level of shared infra that is entirely pre-competitive and turn it into software that is freely shared with everybody.
Just one other point on that. The payers are thinking about this now. So as well as providers, if you want to stay up to the game, you're going to have to be on pace with how the payers are figuring out how not to pay. And they are implementing and looking at AI at a very rapid rate. So every time I speak to a CEO of a hospital organization, I'm like, you don't have a choice now. If you want to get paid, you've got to be in this game.
So we are about at time, unfortunately. As you can see, there's a lot of great questions in the room. Well, I'll take, indeed, there was one more question. I was going to take the moderator's prerogative and be the one to ask the last question, so I'll just go ahead and do that. So we've said a great deal today, I think, that covers a lot of ground all the way from values to infrastructure to sort of deployments, gaps. I'm curious if you were to synthesize a takeaway, so the sort of, is there a thing either directed at public, private, academia, I think any synthesis of all of them, as choices that can be made differently or infrastructure that can be built, but maybe a takeaway on something that you think would really move the needle in public-private partnerships? And maybe Laura, I'll start with you.
I think I'd say let's do this together. Let's not assume that everything is brand new, that we can't build on structures that we had before. Someone mentioned their digital health approaches that they have. Even our privacy frameworks are quite robust. And I think that if we can think about that idea of what can we adapt and use, what's truly new in all of this, and I'd go back to Stephen Hawking, that we've got to keep working together as closely as possible, keep talking, because that's how our greatest breakthroughs happen.
Thanks, Laura. Ken?
Yeah, I mean, I think we probably want to think about this from an economic standpoint. Where can we have the most impact for the least risk, lowest cost type of thing? And I think healthcare costs now in the US are unsustainable. And probably for us, that puts certain disciplines at the top of the heap for a public-private partnership proposal. Oncology is one we could think of and makes sense, cardiology, et cetera. But we definitely would be looking at that of how can we help the most patients, and not necessarily how can we do the best science or develop the best model.
Thanks. Nigam?
Scale. One word. If we don't scale, none of the promised land is going to pan out.
That's a great way to end the panel. So we have about a 10-minute break. Thank you to our great panelists, indeed. Thank you, Nigam, Laura, Ken, for a great discussion.